And good afternoon, everyone. TJ Alds, I-45 now, 288 now, Galveston now, and Clear Lake now, presenting you another edition of UTMB Health Care Unmasked, our monthly show taking a look at different issues in public health and some of the programs that are offered through UTMB Health. And today we have a really fascinating subject to talk about. It explores what's called deep brain stimulation. You'll find out more details about that, and also of what it's used to treat, including, by the way, what's called essential tremors. We'll get more into that here in just a little while. But I want to welcome to the show here Dr. Patrick Harris of the Department of Neurosurgery at UTMB Health, and with him is one of his patients. And that is, I almost called you Dr. Reba Smith of Chemo, who are joining us here today. Thank you all both for being on with us here today and talk about this subject matter. Dr. Harris, let me get with you here first on this. And, what I had said when I first got my notes on this show topic about a month ago, I had to ask when it was sent over to me, I said, well, what the heck is an essential tremor? Why would anyone call a tremor essential? So I thought I'd start with you on that, and you can explain to us what an essential tremor is and what its effect are, because I think it's a term that not a lot of folks, unless you're suffering from it, know about.
Yeah, absolutely. So essential tremor is a neurologic condition that is a involuntary type of tremor that people get typically when they're trying to do a movement. So when they're trying to write or eat or drink or something like that. It's something that generally gets worse over time and can progress over many years. It's a dysfunction of some of the circuits of the brain running from back here, from the cerebellum up to your motor region through the thalamus. There's a deterioration of some of the neurons that leads to this tremor. And it's really the most common cause of tremor in people. It's 10 times more frequent than Parkinson's disease, which is another type of neurologic condition which causes tremor. And we think that there's probably 10 million people in the United States that have essential tremor to some varying degree. In some people, it's very mild, doesn't really affect them. In some people, it gets very severe and can really affect the quality of life.
And in fact, one of the things you told us in our preview interview the other day about this is that patients who are diagnosed with essential tremor, you can look back and find that there's a hereditary link to this, correct?
Yeah, and probably about half of people, they have family members, either parents, brothers, sisters, children, that also have tremor to some degree. And sometimes it's severe for everybody, and sometimes it's only severe for some people that have it.
And so if someone has a tremor, an essential tremor, what does it look like for folks to understand, particularly for our audience out there that, may have a little bit of a tremor or a shake and every once in a while and not know, what that really is. Some folks I'll hear sometimes. I know my grandmother used to say, well, it's just old age out there. Yeah. Can you explain for folks what the signs they should be looking for?
Yeah, so everybody has a little bit of a tremor, which we call a physiologic tremor. If you hold your hand straight out, nobody is perfectly steady. But essentially, it's degrees of that type of tremor. So if you're trying to do an activity, actively holding your hands, and the shaking, is to a much higher degree like this, that is something that we attribute to different tremor disorders, essential tremor being the most common one. It typically is something that it gets worse when you're trying to do an activity with your hands. So things like eating, drinking a glass of water, writing, or talking, people can have voice shaking, and their head can shake also with this type of tremor.
And then you'll hear along the lines of that it'll start mild, and then you said it starts mild for some folks, and then it just gets worse over time. And we're going to hear that from Reba here in just a little bit. But talk about essential tremors. What else folks need to be aware of?
Yeah. So most commonly affected are the hands, but also the feet can be affected, also the head and the voice, as I mentioned. In many people, this gets worse over time. And by time, it's not in a couple days. By time, I mean years, decades. Often people can start having a noticeable tremor in young adulthood to mid adulthood. And then as the decades go by, the tremor really becomes affecting so that it impacts your ability to do normal activities that you want to do. One thing I also ask people is, does their tremor get better when they drink alcohol? Not everybody drinks alcohol, but some people do drink alcohol to make their tremor better, and that can also lead to too much alcohol use. So that's something that I often ask people.
Yeah, because that self-medication part that can cause its own problems on top of that.
Yeah.
And there's ways to treat this before you get to the level we talk about with deep brain stimulation. But talk about there's actually medications out there folks can take for most of that, and that's the most common treatment, is it not?
Yeah, the first line treatment is always medications for things like this. And so if you do have a tremor that's disabling and stopping you from doing certain things and affecting your life, generally the first line medications are something called propranolol or primidone. And these are different medications that are commonly prescribed to help decrease the amount of tremor. And for many people, this is effective, and it can be effective for a long period of time. There are some other medications that can help some people, but tend to be less effective, things of the benzodiazepine or anti-seizure drug class. But in people who, despite trying these medications, are still having a tremor that's affecting their ability to do activities they want to do, that's the people that we talk about next steps, which is surgery. There are different types of surgeries available. Some of these are actually making a lesion in the brain, either with a probe that heats up a part of the brain, or with ultrasound, which also heats up part of the brain, or deep brain stimulation. We think of deep brain stimulation kind of like a reversible lesion. So we put in an electrode into the brain, and it stimulates the brain with electrical activity, but it's something that you can turn on and off. Whereas if we actually make a lesion in the brain, it's permanent. So with deep brain stimulation, we can do it on both sides, whereas with some of these lesioning techniques, we can only really do it on one side.
Yeah. And we're going to get into those options here too. But then there's other causes of the tremor out there that folks need to be kind of aware of out there. That could be, we obviously, we've already had one viewer point out that she, even her sister, had deep brain stimulation for her Parkinson's along the way. So thanks for commenting on that, Mary. But what are obviously we see Parkinson's listed there on your slide, but there are other causes of tremor out there for folks to be aware of.
Yeah. So before even prescribing drug medications, and definitely before doing any surgery, we do want to diagnose what type of tremor people have. Essential tremor, like I mentioned, is common. Parkinson's disease, though, maybe the most well-known one. Parkinson's disease is it's a progressive neurologic disease that's characterized by a resting tremor. It tends to be a little bit slower, and it tends to be when people are resting, not trying to do a movement, that the Parkinson's disease tremor gets the worst. But that is something that also can be treated with deep brain stimulation and different types of medications. So that's one of the reasons medications are an important first step. But tremors can also be exacerbated by other neurologic conditions like multiple sclerosis, or if you have a stroke in a certain area. And it can also be a psychogenic tremor, sometimes caused by very severe anxiety or other things. So it's really important to get the diagnosis right before we go to a treatment.
And when someone wants to, because as I tell you, like my grandma used to say, it's old age, which is the tremors. So obviously at that time, the thought of going in and telling your doctor, "Oh, I have these," and go on. But nowadays, we're trying to make folks a little more aware of what their body's trying to tell them. If someone notices something slight on, is this something better that they go in early and not wait till it gets so severe till it starts affecting their life to do something about?
Yeah, absolutely. I mean, the first line treatment for these is medications. And so if you are noticing a tremor that you think is getting worse, or if it's starting to kind of get in the way of things, it's totally reasonable to go and have a conversation with your doctor about this early on. There are the most specialized doctor at treating these things is a movement disorder neurologist. So my partner here at University of Texas Medical Branch is Dr. Laura Wu in the Department of Neurology, and she specializes in movement disorders. So people with essential tremor, people with Parkinson's disease, dystonia, many of these different types of movement disorders. She's an expert at figuring out which one someone has and getting them started on the right medication.
We're going to be talking about the neurosciences and that movement disorder program that UTMB Health has. But before we get into talking about deep brain stimulation, Reba, let me ask you here a question along these lines. Is that you dealt with these tremors for a quarter of a century, for 25 years, before actually trying to do something about it. Talk about that experience for you, of what that was like.
Well, it just started out slow. Really. And over the years, I guess it started getting worse about 10 years ago, started getting really bad, where I felt like I had to do something about it, but I didn't really know what to do or who to go see or anything like that. And so I heard about essential tremors and familial tremors. And so I thought, well, if that's something that I have, maybe I should check into it further. So about 4 years ago, I started going to see Dr. Elfiki, and that I did have essential tremors. And so we tried a number of medications, and they worked for a little while, but never totally. And so it took 4 years before we realized that we needed to do something else. And that's where the deep brain stimulation came into effect.
Right. How bad did that get for you, though, at some point? You were sharing stories for me that you were having to compensate for a lot of things in your life because of these tremors, were you not?
Oh, yeah, I was. I had to learn to start doing things with my left hand, like eating and cutting food up. Had to use my left hand because I shook so bad I couldn't do those things. Putting on makeup, like women do, I couldn't do that either. And
simple things like drinking a cup of coffee.
Yeah, drinking a cup of coffee was almost impossible because I would spill it everywhere. And so I shook a little bit with my left hand, but it wasn't near as bad. And that's why I went to using my left hand. And I couldn't even write my name. It was so bad.
Yeah. And we're going to see in a demonstration here in just a little bit about how tough that is for you when we get in after we talk about deep brain stimulation, because that treatment's done wonders for you from what you've been telling us here. And we'll talk more about that. And so medication doesn't work, then you look at the surgical options that are there, Dr. Karras, but you then go into deep brain stimulation. And when you hear that term, deep brain stimulation, some people go, uh-oh, government's planting something in our head or something like that. Obviously, I know you've heard that before. So why don't we, talk a little bit about, let's dive into that a little bit so that folks can understand what deep brain stimulation really is and explain how does that work and, what's the basis of going to that level of treatment?
Absolutely. So deep brain stimulation is a device that we implant, and it really has three parts. So the first part is an electrode. Well, actually, this is opposite. The first part is a stimulator that sends electrical activity that's implanted in the chest. And the stimulator, it looks something like this. This is a sample of one of the stimulators. It's a generator. There are a couple of them. This is a rechargeable one, and this one is a permanent one. So you can see there's a bit of a size difference, but it goes under the skin, under your clavicle, kind of just like where a pacemaker battery goes. And then this generator is connected by a wire that goes up behind the ear to the head here, under the skin. It's then connected to a lead. The lead looks like this. It's thinner than the ink cartridge of a pen, but this is the part that goes into the brain. And so it just has little contacts, little electrodes at the tip here, and that's where electrical signals are emitted to stimulate the brain. And for essential tremor, this goes into the thalamus, but for Parkinson's disease and some other things, it can go different areas depending on what neurologic condition you have. And it only goes about this far into the head. It's not very far. The rest of the wire goes under the skin to connect to that extension cable that then goes down to the battery. So that's what it is.
And in the process, and this was where you were just explaining that this is a scan. I should point out, this is not Reba's brain, I don't think, that we're looking at here, are we, Reba? But this gives kind of an idea of where the placement goes, and how invasive is this surgery. So someone, that may be one thing may hold someone off, but how is this done? As you can see, as you were talking about how deep the probe will go in here, but how invasive is this? Because I was looking at this graphics. Oh, someone sees this, they may get a little concerned here on that. Explain that process.
So it is a process. It is a surgery, but the risks are pretty low. So what we do is the size of these targets in the brain are very small. They're maybe a centimeter big, and so we have to use a stereotactic system, which is something that lets us get to a sub-millimeter precision to target an area in the brain. There are different ways of doing that. One of them is with the stereotactic frame, which is what you see, that blue device. And that's affixed to the head during the first part of the surgery. And that's what lets us guide these electrodes into the exact location using that frame. We also have some techniques that on the other side, that robot called the ROSA, that's a robotic stereotactic system. And we can use that too. Both systems are equally good. They both have sub-millimeter accuracy in allowing us to implant these targets into the brain. But it is a surgery. So there's an incision about this big on the top of the head, one on each side, and then also an incision on the back of the head to do the connection, and one over the chest. We do the surgery in 2 stages. The first part of the surgery is implanting the electrodes into the brain. And for that part, we actually have our patients awake to make sure that we're in the right location and that they're getting effective therapy when we stimulate the electrodes. You were awake during surgery, and we were turning the stimulator on and making sure that your tremor went away, and it did.
And it did. Yeah.
And that's how we know that we were in the right spot. And then afterwards, a couple weeks later, we put in the extension cable and the generator. And then after that, once you have a little time to heal, is when we turn the device on and you get the therapeutic benefit. So it is a commitment.
Yeah. And let me ask you, Reba, how weird was it for you to be awake while someone's basically screwing around with your head?
Extremely weird.
Yeah.
I was really nervous. I mean, doctors can tell you, I was extremely nervous before we went in. And even when I got into the operating room and they started putting that halo on my head, that was kind of scary.
It's involved, but as you said, it's safe. How routine are these type of surgeries? We talk about how about the tremors are probably routine, but how routine are these surgeries now, Dr. Karras?
We do these surgeries relatively frequently. We're doing them at least every month, and hoping to do them more frequently. But it's a standard part of neurosurgery now. This surgery has been around for 15, 20 years. So it's something that's definitely standard of care, both for essential tremor and for Parkinson's disease.
For those of you who are just joining us here, we're having a really interesting conversation about what's called deep brain stimulation. It is a surgery, as those of you who are listening here will hear, but it is used for different things. We're talking about essential tremors now. Let me get into this with you, Reba. We talked briefly about the process there, but I want to talk about your life up until then, because you were compensating along the way for the better part of, you said it got worse about 10 years ago and really progressed and changed your lifestyle, that you went from being right-handed to left-handed.
Yeah,
in this process to accommodate. But even with that, there were certain things you couldn't do left-handed. The one that I think that caught me when you said the other day is you weren't able to use your electric knife that you like to use when you're cooking or
exactly.
serving.
I could not even carve my turkey for Thanksgiving. Someone saw me shaking, and they said, "Let me do it."
Yeah. It is one of those things. I think, folks take certain things we do every single day for granted. You brought into that kind of reality of when we lose even some of the simplest of things, it has a bigger effect on you than just, hey, I can't carve the turkey right now, right? Not emotionally, and how you feel you're represented in public.
Well, I had to hide I felt like I had to hide my hands all the time so I wouldn't shake, so people wouldn't, I guess, feel sorry for me or think I had Parkinson's or whatever. But I was just embarrassed because of the shaking. So I think
Yeah.
that was the worst thing. And, you're trying to eat in front of people and you're shaking, you can't get it to your mouth, and you're dropping food all the time. That's really bothersome.
And so did you find yourself not participating in certain social activities because of your condition, or did you just
Really.
try to muscle through it?
Oh no, I wouldn't hardly do anything. I
And
couldn't do,
now, no, go ahead and finish up what you were saying.
some of the most simplest things a lot of times. Anytime I went to use my hands, they would start shaking. So,
And then and how did you find out about going in for the treatments first? About, hey, you said you've heard about essential tremors. How did you become aware of that to say, you know what, the problem I have is different. I need to go get this taken care of.
well, I had been seeing Dr. Albicki for about 4 years, and when we realized the medications didn't work, then he mentioned deep brain stimulation and mentioned me going to Baylor. And so, in the meantime, in between that time that I was waiting for a call from Baylor, I went in to see my orthopedic, and they noticed that I was shaking. And they had mentioned, or I went to see the PA one day, and she mentioned to me that did I know I had an essential tremors, and there's a cure for it. And she mentioned deep brain stimulation as well, and said Dr. Karras was coming here from Baylor and that he specialized in deep brain stimulation. And would I want her to make me an appointment? I jumped at the chance.
I mean, just to be able to say that, get those simplest things in life back into normalcy for you along the way. And in fact, we're going to bring up a video now that that this is something we did yesterday. You were doing a follow up appointment, and this is, we're going to be showing. This is when the device is off. Am I right here, Reba?
Yes, we turned it on around 9 o'clock yesterday.
Yeah,
So
you turn it off
that,
before you went in there, and you can
yes,
see in that right hand how the tremors go, and they're monitoring you the whole time. Um, and when how quickly do you notice the difference of when we're watching you try to write right now but how quickly do you notice the difference when the device is turned off?
about 10 minutes after I noticed right away that there's a kind of a different feeling in my head. And, but then I noticed the shaking came back like 10 minutes after.
And right here, this is you after you sign your name. You're trying to draw a swirl
Yeah, yeah.
here. We're gonna show it up here. As it and by the way, and I don't want anyone to think we're doing this because I really do appreciate Miss Smith of allowing folks to see this, because there are so many people out there that are having these same issues that can be done with. And now, and this is the technician here from the firm, the technology firm that works with UTMB Health on this. How quickly, when they turn the device back on, do you notice the tremors kind of subsiding?
Well, they go about it slowly because you don't want to just put it full on. So he does it in like shifts. And so I noticed a little bit, my head will stop shaking, my voice is controlled, and then slowly the hands quit shaking.
And is this something of, does it, and it doesn't, and one of the things too, Dr. Karras, is that it will not take any of the shaking away 100%, but it reduces it by a significant amount, correct?
That's right. I usually tell people that they should expect 80 to 90% reduction in their tremor in their hands and arms after deep brain stimulation. A lot of people also get it to really decrease the amount of head tremor and voice tremor. Ms. Smith had a great reduction in both her head and her voice tremor. But that response is a little bit more variable often, but 80 to 90% reduction in your hand tremor. And I think for most people, that is enough to get back to doing all of the things that you want to be doing again. And I have to say, as far as all people across neurosurgery with different things that I treat, people with tremor after this surgery are some of the happiest people that I get to take care of.
That goes right into what I was going to ask you. You told me on Monday when we talked about this the first time that, the biggest thing was you had to teach yourself how to write right-handed again, correct?
Yeah, it was pretty messy at first, but then it's gotten better, and I hope that it'll get back to normal the more I write.
In a little bit, you'll see her hold up the piece of paper that shows the difference of when she has the device turned on and when it's been turned off, and you can see as they're progressing here, and we'll make this video available to anyone here too to kind of get the full feel of how much the head, because we can tell just watching this here how it's changed as we're watching your response here, as you can see that progression go. Now, you talked about, Reba, you talked about how you yourself, you avoided a lot of maybe social interaction, didn't do much of anything. Now you had this, how that changed what you do out in the public life?
Oh, we go out to eat all the time, and we're going out to parties and getting together with friends and playing cards, without shaking. That's one thing. Yeah. And I can
you're better at cards now. You don't drop a card to give away what your hand is now, right?
Exactly.
So there's hoaxes as we keep watching this. Is that also used for, now this is right there. Let's just let that, just picking up the cup, because when it was first handed over to you, you couldn't even pick it up. You knocked it over and you had to use two hands. And this is only a few minutes in of the device turning back on, and you were able to pick it up and hold it. You still had a shake, but you were able to, it calmed down enough that you were able to grab onto that. How often do you have to do these follow-ups in which, just kind of measure your progress?
Well, right now I was doing it every 2 weeks, and now I'm going to once every 2 months.
And you had this surgery done earlier this year, correct?
I had done January 20th was my first surgery. And then 2 weeks later, I had the second surgery.
And for someone that may be a little worried because they saw the head contraption too, so there's the deal. This is just amazing. Now, just the progress from what it was earlier to now, even just gripping it, turning it, not fearing about dropping it, not having to use both hands. That alone is kind of the simplest example of how this is working well for you. If someone were to be a little nervous about having this procedure, what would you tell them yourself, Reba?
Oh, if they're nervous about it. I was nervous when I first started talking about it too. And when it came down to doing it, I was still nervous. In fact, I cried when Dr. Karras came in to talk to me. And it's just the end results are so worth it. It's just life-changing.
It's just getting past that kind of mental block of, hey, this looks a little scary. They're going to put this halo. I'm going to be in a surgical deal, and then doing it, and then and seeing what you've been able to do in your life since then.
Yeah.
I mean, we're just talking about a few months ago that you had this done, and already how dramatic it's changed your life.
I'm happier. I'm a happier person today because I'm out there doing everything that I didn't do before and doing
And
things that I couldn't do.
one of those things is for you, and well, let me bring back to this, because this is you signing your name again, and this is after the device has been turned on for a while, and again, you know, you had to learn how to write left-handed, and you're doing a spiral here. Now look at the difference here. We're going to hold this up here in a second, or you're going to hold this up in a second. I want everyone to look at the difference. The top there is when you came in.
Mm-hmm.
The other one is, shortly after the, device was turned back on. And this is, about 10 minutes after.
Right. It was even worse prior to me doing the deep brain stimulation.
Right.
You couldn't even read my writing.
But now you would pass. No one writes cursive anymore, teaches cursive anymore, but you could pass your cursive class in school with a 100, I would think, with that there. You did a great job.
Thanks.
Dr. Karras, let's talk about an important part, because I know there are some people watching this going, well, you mentioned Parkinson's, you mentioned other things that are out there that maybe, to look at that deep brain stimulation could help. Can you go over that a little bit of what else it's approved for use, deep brain stimulation is?
Yeah, absolutely. So we talked about essential tremor. We touched on Parkinson's disease, but deep brain stimulation, people with Parkinson's disease often have a tremor, but they often are very rigid in their limbs, and also very slow moving. And deep brain stimulation can also help those two symptoms of decreasing the rigidity that people have, and also decreasing the slow movement, the bradykinesia that they have. Another indication is dystonia. This is often in younger people. It can be genetic, but they have uncontrollable movements in their arms or legs, or different contractions. And deep brain stimulation can also be a treatment for that. One of the kind of not movement disorder or neurologic conditions is obsessive compulsive disorder. And this is not obsessive compulsive disorder as people casually say it. This is for people that have been on multiple different medications for obsessive compulsive disorder and are disabled completely by obsessive compulsive disorder. And so if you see a psychiatrist and they have you on multiple medications, deep brain stimulation is something that can also be used to decrease those symptoms. And then the most recent indication is for epilepsy. So people that have tried multiple different medications for epilepsy and have something that we call drug-resistant epilepsy. So that means you've tried 2 or 3 different medications, but still continue to have seizures. Many of those people can benefit from deep brain stimulation or some other surgeries. And for that, we target the thalamus as well. And that can help to make people either seizure-free or decrease the frequency of seizures that they have. So these are the 5 FDA-approved indications. And then there's a lot of investigational studies going on for things like depression, is a big one. People are trying different targets with depression. Things like Tourette's, where people have tics that they can't control. That's another movement disorder. So there's a number of different investigations.
As we back up here too about what it's used for along there, one of the things we should point out there, essential tremor, the FDA approved this being used as a treatment back in 1997. So this is not a new treatment on the block. This has been around a good while.
Yeah, it's definitely tried and true. And what's nice, though, is the technology has continued to improve. So the types of electrodes we implant are more sophisticated, and the type of programming we can do to generate the electrical stimulation is also more sophisticated. And that's really helped to improve the efficacy and decrease side effects of the stimulation during the treatment.
And in your case, you had said to me Monday when we did our preview, and mentioned it briefly here, but we're talking, when this is done, is this long lasting, or is it like, okay, maybe it'll be good for another 10 years and we have to look at something else? What so far, they're based on particularly like essential tremors, we'll start there, so that's what Reba has to deal with. Is this become a permanent fix?
Yeah, this is a long-lasting treatment. In some people over 10, 20 years, the effect can decrease a little bit, but it's a pretty solid long-term treatment. One thing people should know with the generators, there's two types, as I mentioned. One is rechargeable and one is permanent. The rechargeable generator has to be recharged every 1 to 2 weeks for maybe 30 minutes to an hour. And that lasts about 15 years before it would have to be replaced. If you choose to have the non-rechargeable battery that you don't have to do anything with, it just sits there, that lasts generally about 4 to 6 years. And then you have to have it replaced. But the replacement is just reopening this part here. It takes about 30 minutes and it's a same day procedure.
But for those that have to do the recharge of the other ones, how is that done? Because I mean, are you plugging yourself into the nearest socket, or and that's what I say. That's what Reba's going to show us here in person and also on the video here. Essentially, this is kind of like how I charge my iPhone, right? I mean, it's you put this around your neck and it gets recharged that way.
Yes. You put it around your neck. I brought it with me today as well. So you put it around your neck, you turn on the button, and it beeps. And when you have it in the right place, it'll stop beeping.
So again, if anybody is familiar with how you charge the new iPhones, you put it on the pad, and then that's how it charges, and that's how you're able to do that every 2 weeks or so, right?
I do it every once
when it's done.
Yeah, once a week I charge it up. And I watch TV or write a letter or whatever type of letter. But that's all it takes.
And how long do you have to sit there with it to charge up?
30 minutes. No, about 30 minutes if you do it once a week.
And then that device, the recharge device, you then go plug it in and it then holds the charge for later. Is that how it works?
Oh, yeah. In fact, you don't have to leave it charging all the time, but it'll make it last longer if you do charge it all the time.
Gotcha.
Charger.
It's something else that the potential that this could have. You've talked about Dr. Karras, you talked about what's being looked at for the potential of deep brain stimulation being used into the future and the advance of technology. What are some things that may be looked at that are way down the line before we have any hope out there? I specifically asked you the other day and wanted to hear your answer again on dementia and Alzheimer's, for example, and what potential that may have. And is that being looked at right now? But what else do you see this as a potential for down the line?
It's explored for a lot of different things. I think, the most common things that people are exploring is definitely depression. There have been a number of studies in depression, and people are investigating different targets. Alzheimer's, it's earlier in research still in Alzheimer's. There haven't been big trials or anything like that. And then for epilepsy, one of the interesting things is there are different targets being investigated. Epilepsy is a really common illness that I think surgery is also underutilized for. Oftentimes people are started on 7, 8, 9 different medications before they see a surgeon for different types of treatments that might be more effective. But we're investigating different targets in the thalamus and around the brain to try and decrease seizure frequency.
If we were to to look at things in kind of a retrospective way of how this came about, can you kind of give us the history of how deep brain stimulation came to the forefront here? Because I find that fascinating. Is that when somebody has a treatment that's not been thought of before, is that somebody somewhere had to say, well, if we stick an electrode in the brain, it could do this. I mean, it's amazing that someone thought of that at some point. Can you talk about the history of how this progressed to where we are now?
Yeah, a lot of it came about treating the tremor and treating people with Parkinson's disease. And a lot of the earlier trials with it were people used to make lesions in the thalamus or the globus pallidus or the subthalamic nucleus in the mid 20th century, so 1950s. And that was becoming a common thing. Again, this is creating a lesion, inserting a probe and creating a lesion in the brain. And that was becoming more common until in the 1970s, levodopa came out, which is a medication for Parkinson's disease that's very effective. At that time, that kind of decreased the use of surgery for Parkinson's disease until the 1990s. There was a neurosurgeon named Dr. Benabid, and he was one of the ones, he's considered the father of modern deep brain stimulation. He did the implantations to treat tremor in people with Parkinson's disease and essential tremor, and it really took off from there. So there was kind of a delay from the 1950s up to the 1990s when the technology was catching up to be able to do the stimulation. And the reason why the DBS became common was because, like I mentioned earlier, it's the ability to create a reversible lesion. So these targets are very small and they're next to some other important structures in the brain. And if those structures get stimulated or damaged, you can have some different side effects, trouble talking, numbness in the arms, or muscle tightness. With deep brain stimulation, we're able to actually steer in which direction the electrical current goes from these stimulators now, and that helps to minimize those side effects. And also, if people are having side effects, we can turn it off or turn it down to help modulate that. And that's what allows us to do it on both sides, and that's what allows us to do it very safely.
And in the and this all deals with putting stuff into your brain, but really, how much do we, as this as a neurosurgeon, but let me ask, how much do we really understand about, particularly in the sciences, how much do we really understand about how the brain functions, and how much do we not understand, I guess, is the most important question here at this point.
That's a hard question to give a short answer to, but
you got 20 minutes, so you're good.
I think that we understand it on a very basic level. We understand that if we were to create a little lesion in the VIM nucleus for essential tremor, it stops it. But we don't really know necessarily, and we know the pathway. We know that there's a dysfunction in the connection between the cerebellum to the motor cortex and the premotor areas that's leading to this tremor. But we don't have all of the details sorted out, and there's still a lot of active research going on. One of the things that's interesting in active research is some of these devices, and this is more common in Parkinson's disease, but now we're starting to actually record the brain activity, and we can see that certain frequencies of brain activity in Parkinson's disease are correlated with symptom severity. And so there's new technology to be able to start to change the stimulation settings in people with Parkinson's disease based on that data that we're recording from the brain. And so that's an exciting kind of next frontier of these stimulation technologies.
So you really see this kind of jumping more and more and more as you're able to, the lack of a better term, map the brain and how it reacts to certain things, to be able to say, wow, we know this now, so let's go ahead and try this to combat that. I mean, that really comes down to it, correct?
Absolutely, yeah. And the mapping it's advancing a lot. One of the things we do for epilepsy surgery is we often do mapping with an invasive study to figure out where the seizures are coming from before we determine a treatment. And to do that, we implant electrodes, kind of like these deep brain stimulation electrodes, but we plant multiple of them into the brain in different areas to map where the seizures are coming from. And during those, if you stimulate those electrodes, you can do functional mapping of different networks of the brain, which has helped to advance this type of stimulation a lot. And so that's a common way of people are doing things now. There's a couple of trials for depression where they insert the DBS electrode and insert the other electrodes into the brain and do the stimulation to map how people are feeling based on what sites are being stimulated and where they're recording from. One of my mentors, Samir Sheth at Baylor, has pioneered a lot of that work.
Yeah, it's always fascinating when we get into the neurosciences and talking about the brain, because how much we don't know is so much larger than what we do know. It's kind of like when we talk about oceans, what we know about our oceans versus the other. Reba, it gets down to is that these type of procedures are effective if your life is better. how much better is your life now compared now to where it was before January?
Oh, it's 100% better. I can't, I can't imagine not doing this because it's that good now.
And not to be have a lot of vanity out there, but that when you're out in public or anything like that, do you have to change what you wear or anything like that because you've got basically a battery sitting underneath your chest there?
Not me. No, not at all. It's just a little small bump, and it just kind of blends in. There's a little slight scar, but it's nothing that I would worry about. It wouldn't keep me from wearing something low cut.
Gotcha. So it didn't really affect anything from that. How soon was it before your friends started noticing? You talk about playing cards and how soon before your friends started noticing the tremors were gone?
Oh, right away. My girlfriend, as soon as I started talking, she said, "Your voice sounds normal." She said, "You don't have any shaking in your voice anymore." And so
And
they
you
were
also
really,
got. I'm sorry. What
sorry.
were you saying?
I said they were really excited for me. So
How'd that make you feel? I mean, having your friends around, being as excited for you as yourself.
it made me feel really good, really comfortable. I never realized how bad my voice shook until it didn't shake anymore.
Yeah, and part of it because you were compensating for everything else, right? You were compensating for everything else, so yeah, it just came along that way. And you've been able to return to another passion of yours more often now, making jewelry, right?
Yes. Yeah, I
Talk
have.
about that.
Well, when you shake so bad, I do a lot of wire weaving and wire wrapping, and you have to be able to use both hands. And sometimes you have to, put together something that has little bitty pieces. And now I can do that, whereas I couldn't before.
That's something else. Reba, thanks for being on with us today. We appreciate it. And thanks for agreeing to share your experience out there. And so, Dr. Karras, let me ask you on this one is that, a lot of this is coming through the movement disorder program at UTMB Health. And tell us a little bit about that program. And folks that maybe say, okay, I've got the tremors here, but what else could they be coming into that program to have taken a look at?
Yeah, so like I mentioned, I work really closely with my colleague, Dr. Laura Wu. She's a neurologist. I'm a neurosurgeon. We do all these things kind of hand in hand. Tremor is one thing. Parkinson's disease is another big thing. People with Parkinson's disease don't all have a tremor. A lot of them, like I mentioned, they can have really slow movements. They can have stiffness of their arms and legs, and that can be progressive over time. And so if you're having symptoms like that, I would recommend going to see a movement disorder neurologist like Dr. Wu. Other things for movement disorders are dystonia, which is when you're unable to control some of the different movements in your arms or have increased spasticity. And so they're listed here. Tourette syndrome is a tic disorder. So if people are having uncontrollable muscular contractions, they can get help for that. And then spasticity, which is again very increased tone, that can help. So
and we have the link, by the way, for the program there. If you think in any form, see your doctor, ask about the program. But then if you have any questions, you can reach out to the team there, and then they can help you out as best as they can there as well. And I hope to have you on again here too, Dr. Karras, as we talk about some advancements in this technology along the line, and to see, and hopefully we've shared, that we've been able to, thanks to Reba here too, that put some people's mind at ease. Big question. Someone's going to ask this, so let me ask it for them. Here is this covered by insurance? Because that's always a big question.
Yeah, it is covered by insurance. The vast majority of insurance providers do cover this. It is considered a standard of care for essential tremor and for Parkinson's disease. So that is a common question, and the vast majority of insurers do cover it. It is covered by Medicare as well. You don't have to worry about that if you're over 65.
Good. So it's good information for everyone to have. Dr. Harris, Reba, thank y'all so much for being on with us here today. If you have just a reminder for our viewers here, as soon as this show is over, you can watch the replay. We encourage you to share it with your friends out there along the way. We also have a special story coming up on this, in which Reba will be a part of as well, that our Paul Deaton was producing yesterday. So thank y'all both for being on with us here today. Any final thoughts before we wrap up here today? Either you, Reba, or you, Dr. Harris?
All I can say is, if you got essential tremors, and look into it, because it's so life-changing.
Yeah. Like I said, it's a really a privilege for me to be able to do this, because people are so grateful, and I'm just happy that I can do what I can to help.
Yeah, and I'm sure, and it's one of those things you can almost see that immediate response once you're done too, right, Dr. Harris? It's like,
Yeah.
Sometimes you have to see the kind of the treatments take place, but here you're able to see it pretty quickly, the immediacy of the work that you do there. So thanks for sharing today. We appreciate it.
Thank you for having us.
And a reminder to you folks too, if you want to find out, you can get up close to some of this possibly as well. If you're looking for a career and you're in a medical profession, we have a career open house at UTMB Health that's coming up next week, April 27th and the 28th, from 9 a.m. until 4 p.m. It's going to happen at the League City campus. That's Medical Plaza 1. Medical Plaza 1 is over by the parking garage there on the Gulf Freeway. So you can come on in and do that. And we have the link there too to get more details about the positions that are open and more about the open house. But that's happening April 27th and 28th. And we look forward to making sure we're going to be out there as well, not hiring anyone. We're going to be out there covering it. So we hope to see some folks. If you know someone in the medical profession that are looking for a job, make sure they go to the League City campus of UTMB Health next week. And we look forward to seeing folks out there as well. We've enjoyed the program today. Hopefully you did as well. We're going to be back next month, third Wednesday in May, with our next episode. We haven't decided just yet what our format was. If you have a suggestion, feel free to email us or send a direct message about some topic you would like to have covered here on Health Care Unmasked. We'd be more than glad to take those suggestions along the way as well. Until then, I'm TJ Alds, I-45 now, 288 now, Galveston now, and Clear Lake now.